I didn't give her a very good description of of what to talk about. I just said whatever's in your heart and mind, which is almost unfairly large. But she was, I was impressed that a neurosurgeon was the organizer, and apparently with the co-organizer with for Indivisible on the April 5th rally. And Mike pointed her out to me, and I thought, oh yeah, let's see if we can get her. And she agreed to speak to us. So uh, she said she's happy to answer questions. She'll speak maybe briefly. But Dr. Kim.
Well, just a point of order. Can we check with Dr. Kim and make sure she's okay being recorded?
Oh, Dr. Kim, are you all right with the fact that we're recording this?
Yeah, that's fine. Yeah.
Okay.
I'll try to be mindful. Um, so yeah, thanks for the introduction. I'm Esther Kim. I'm one of the neurosurgeons at Samaritan at Good Samaritan Regional Medical Center. But everything I say is outside of my work, so I just want to be clear. And that's part of why I think by and large you may not see a lot of healthcare professionals in the political sphere. I mean, there are some, and obviously we know that there are physicians that go on to have political careers, but because there are other avenues for healthcare professionals to advocate. But I'll give you just a little background of myself. I'm actually from Southern California. I'm from Los Angeles, and I grew up in LA. I went to train and do my undergrad on the East Coast. I went to Hopkins for undergrad, University of Maryland for medical school, and then I returned to Loma Linda, which is in Southern California. I don't know if you guys know much about it, for my neurosurgery residency, and so I was stayed on um, uh, as an attending after that so I was there for about 12 years. And then I transitioned to kind of from academic medicine to a community practice up here in Corvallis. And so I did a year of enfolded fellowship at Swedish, which is in Seattle. And so that's kind of how I came to know the Pacific Northwest and really loved a lot of things about the Pacific Northwest from that time. And so my husband and I have really wanted to move back, move up here as when I changed locations. And so I came in 2021. And so, yeah, just as we were coming out of the pandemic. Um, and December of 2021. And so I've been here since that time. And my practice is predominantly general neurosurgery. I do kind of brain and spine surgery, with the majority of my practice being spine surgery, because that's what most general practices need, I would tell you. Um, and so then to kind of go back to kind of my political segue in that time, I think as many people experienced after 2016, um, that was a real turning moment for me. One, I had capacity to have um, some time and thoughts and be able to do actions outside of my medical training because I had graduated in 2015. And because training time is just so busy, like you have no time to do anything else. And so once I graduated, I had some space. And then with everything that happened in 2016, I joined Indivisible in Southern California. And that's how I kind of got a little bit of taste of the political advocacy. And so I did a lot of protests, a lot of rallies in Southern California at that time. But then my practice got really busy. So I really wasn't able to do much past that, other than a lot of kind of fundraising through my online groups that I don't know how much you guys there are a lot of Facebook groups of particularly women physicians that were really outraged, and they give a lot of money. So So that's kind of what I did a lot for my political advocacy after my practice got busy. And then when I came up here, and obviously with the last election, that kind of revitalized. And then the Indivisible Benton County got reactivated as a group. And so they just got reactivated this past February, and actually, sorry, March, and they needed help. And I was like, I've been a part of Indivisible before. I'm happy to help again. And so, that's how I developed into becoming one of the core leaders of Indivisible Benton County. And I live in North Albany, so I'm kind of like in this weird space, right? I'm a part of Benton County because that is where North Albany sits. But at the same time, most of my immediate sphere of how I spend my money, the school systems and all these things is really Albany. So I kind of, have one foot in one of the other. And the Indivisible Albany group really was just an online group. And I think community is very important in terms of getting the message out, changing people's hearts and minds. And so that's why I kind of went towards the Indivisible Benton County group, because they were more about in person and building community. As Mark mentioned, we worked with multiple different groups to get hands off April 5th off the ground. I don't know how many of you were there. I know there's several, but we had definitely a very scheduled speaker setup. And then obviously we know that the culture of Corvallis and Benton County is also to protest, as I'm sure you guys all know. There's a weekly protest, there on Saturdays with particularly the Solidarity for Palestine group. But it's a very active community, a very active politically active community. So we helped with hands off, and then we've shifted, even though we're going to participate with May 1st and May 3rd. We're going to have a booth and set up a first aid station for people and assist other groups that are hosting those protests. A lot of what we try to do is create actionable items. That's actually the reason why I joined Indivisible, because they're action oriented. It's good to talk about things. It's good to, discuss like how people feel, how do we want to message, but I think we can't make any change without action. And so that was one of the reasons why I joined Indivisible. And so we have a website running. We have a very active Facebook group. I think we have 1,000 members in our Facebook group. We've got our subreddit up and running, trying to reach younger voters, and then an Instagram account as well. So we've developed kind of a really robust action committees. We're just still starting. We're just getting from the ground up, and that's kind of where we are. So I'm here to answer your questions. So that's a little bit about me, about what my activism looks like right now. And really, I'm just here to be a resource for you if you guys have questions as overall a healthcare professional or my work with Indivisible. Yeah, however I can be a resource.
And if you could, Mike, if you could put a spec where I can see everybody on the screen and folks can raise their electronic hand. Thank you. And I'll call on you. And Fritz has his hand up. Go ahead.
Actually, I think Alex and Linda were before me, but I'll go ahead.
Oh, sorry. Yes.
Yeah, no, that's all right.
Alex, and then Linda, and then Fritz.
Thanks. Hi, Dr. Kim.
Hi.
I had a question for you. So you led right into it because you mentioned that a lot of doctors don't really get involved politically.
Yeah.
So I was wondering, I'm going to talk about some legislation later that coming up that just kind of addresses that. But I was just wondering, I mean, I know it's just totally your opinion, but how much of it for doctors keeping to themselves, their feelings about anything political or what's going on, addressing healthcare issues? Is it how much of it is like uh, there's non-disparagement clauses in their contracts, but
Mm.
how much of it do you think is that versus how much of it are really afraid for their careers to like really speak out on stuff?
So I will tell you, just like the general population, healthcare professionals have a variety of different opinions. Okay. And some of it is appalling to me of what I see. But and so I think I think the easiest way for healthcare professionals to get politically involved is actually within their own state societies. So for example, so when I was in California, I was actually very involved within our own state society. So um, for neurosurgeons, for example, I don't know if you guys know this, we have our parent body. We actually have two parent bodies, but anyhow, within our parent bodies, they're actually an organization called CSNS, which is the Council of State Neurosurgical Societies. And each of the different states, very similarly, if you think about the parliamentary system, have their own state societies of neurosurgeons, and they act like political bodies in a way where they talk about what are the issues that neurosurgeons want to address. And by and large, this is very common because even in California, outside of neurosurgery, there is the California Medical Association. So the California Medical Association is obviously a body that represents multiple different professional societies, and they all meet. There's a yearly meeting. And I will tell you, California is one of the most progressive of the medical societies because one of the referendums or resolutions that I remember seeing was the reaffirmation that that poverty and um, socioeconomic forces, right, is what drives healthcare outcomes. You know, so it's a very progressive medical association. And so each of the different specialties, each of the different medical associations, they have their own political methods of trying to get their message out. Whether they go up the AMA train, which is the American Medical Association, which has its pluses and minuses. I think they've done some pretty bad things sometimes in the past. And, you know, and part of that has been their pro-business approach, right? Because of private practice, you know, and so by and large, people that are politically active in the healthcare like profession tend to use those methodologies that they kind of reflect their specialized skills, their expertise, right? In just talking about medicine in a way or healthcare. But that's the other part is some people just don't care. I'm sorry. I know that sounds really, really sad and really kind of but to be honest, I think some people they don't understand the political ramifications and they're so busy with their own practice that they just don't have the bandwidth. And 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 I can understand that to a certain degree, but I think the reason why I'm politically active because I recognize the policies affect the health of my patients, right? And so that's another way for me to advocate for my patients is to be politically active, if that makes sense. So that's just the way I think about it, but that's not how everyone thinks about it. So hopefully that answers your question, Alex.
Thanks.
Yeah. Let's go on to Linda.
Hi, Dr. Kim. Thank you. So I have a question about Indivisible. You mentioned action committees.
Yeah.
Is there a specific action committee around healthcare? Somebody that we should be maybe partnering with to get our messages together?
Yeah, that's a great question. So the way that Indivisible works is that we're really a coalition building committee, a group, because we're not focused on one single topic. And so part of that so our action committee, so I'll just kind of go through what our action committees are. We have a communications action committee that works on all our different platforms. That's the one I run, so that's what I can tell you about. We have a voter outreach, get out the vote action committee. And we're doing a canvassing event on May 3rd and May 17th for the special elections that are coming up, right? We have a legislative oversight committee that looks at federal, state, and local statutes or just things in terms of what to watch for. And then we have a different committee called partnership, outreach and partnership. That's the name. And so in terms of so that outreach and partnership has multiple different subgroups based on what the group seems to be interested in, but also understanding what the needs of the community are. The healthcare aspect would probably fit potentially with and I don't know if they call it healthcare. I know they divided it more into Medicare, Medicaid. So that could be potentially the group that plugs in. Or if there are specific legislative things that is on your radar, it could also go to the Legislative Oversight Committee. So those are probably the two. Then after that would be if there's like things that you want us to promote, like activities. Like one of the things that we've been working on with our Facebook group, there's a very active person promoting the food bank status. So we have been taking some of that information and posting it on our website, blasting it on Reddit and Instagram and those types of platforms to get more visibility on some of those community issues. So there's a couple of different ways that we can connect is probably what I would say. Yeah.
Right. Thank
Right.
you. Thank you, Dr. Kim.
Thank you. And let's go on to Fritz.
Dr. Kim, appreciate you being here with us tonight. We actually exchanged an email about the upcoming May 31st, and I know we'll have a conversation about that. Just to provide a preface to why I'm about to ask this question that I ask of many providers, specific to the potential implementation of universal health care in Oregon. Been in healthcare for over 40 years, mostly on the business side.
Okay.
Provider side, insurance side, got about 20 years of revenue cycle experience. The question I have really is from a provider's perspective. I fully believe that if a state had universal health care and a provider and their staff are not having to deal with dozens of different insurance companies, how effective would that be as a recruiting tool to recruit more providers to the state of Oregon?
That's a very interesting question. I would say it depends on how that program is implemented. Okay. I would say, for example, Kaiser does a great job, okay, of administering and prioritizing and messaging across their groups. But also it's interesting how they work because each of them are somewhat siloed by by territories, which is really interesting. But I think, even because one of the things we talked about in the email, and this is one of the things that I wrestle with is that when we deal with healthcare and money, right? There is, and if you look at healthcare finances, there is an element of rationing, right? That occurs, that has to occur, right? And whether or not you use single payer, whether or not you use multiple insurance companies, there has to be an element of rationing. And even in OHP, right, which is who I deal with day to day, right, there is rationing of care, right? There is a line item where, like for me as a spine surgeon, right? I came from California, right? Where Medi-Cal, I had full breadth of pain management options for my patients, for example, right? So when I came here, I was kind of really surprised by the lack of access to pain management for my patients. Because I mean, I mean, you you would have to probably ask some of my patients, but I'm probably the most or very like one of the most conservative spine surgeons you'll meet, right? And so I would really want my patients to have full mode of conservative management prior to doing surgery, right? OHP does not allow me that. It's either medications, PT, or surgery. That is it.
Wow.
So I think a lot of it has to do with implementation. And I do believe that, like Medicare, Medicaid, are very efficient systems, right? Like, I don't believe that there is waste, fraud, and abuse in our Medicare and Medicaid system. Like, I think that is absolutely false. I think the administrative costs are far less than our other insurance companies. So I bristle at that when I hear that from people, right? And I think ultimately the information that you find out, if you actually look at the data, will support that, right? And and just to go to your question, to actually answer your question, will a single payer or a, universal healthcare model be I don't know that the plan itself would be a way to attract people. I'm sorry to say, like, I don't know that that's how providers think. I think you have to understand healthcare professionals or people. They want to be able to, have food on the table, have a safe place to live, be able to raise their children in safe neighborhoods. Like, these are the things that we do look at when we're looking at a location, right? And are we making a wage that is comparable across the country? Like, these are the things. Yes, I think for us, we know that having to deal with insurances is just part of the game. Will only having a one system, one insurance, one healthcare provide like insurance company system be an attractive thing? I mean, I think people who went to the Kaiser system would say yes, because they don't have to deal with it, right? It may definitely attract a certain population of people, if you implement it well and you provide, the benefits that are attractive. That's how I would say it. It's not going to be just because of the plan.
Sure. Sure. I get it. All right. Thank you.
Of course.
Okay. Mike, could you put us on full screen again so I can see if anybody has their hand up? We'll take a couple more questions. But I can't see people right now.
I think Alex has a question. I see his hand up.
Okay. Alex, go ahead.
Well, I didn't see anybody else raise their hand, so sorry, you didn't hear from me.
All right.
But kind of following up on Fritz's question, though, it was a really good question. So, and then it made me think because, right now we've got a Universal Health Plan Governance Board that's working on a Universal Health Plan. But before there was a task force, and when they looked at provider reimbursements, they kind of acknowledged. I mean, they didn't really delineate exactly what the plan's going to be. That's going to be up to the current governance board.
Mhm.
But they looked at kind of that the emphasis would be on primary care, and kind of alluded to the fact that, well, you're going to have to bring up salaries in primary care to affect what they want, which would probably bring down specialists.
Yeah.
So just following up on what Fritz was saying, what's your? I mean, if that were to take the case, would that make recruiting and bringing, providers coming to the state that much worse? Like, if there were some balancing going on there, what's your opinion of, just off the cuff, of how that would impact the ability to draw providers here.
I'm going to tell you it's already difficult to recruit to this area. One, I think people fail to realize that you're not just recruiting the provider, you're recruiting their family. If their family can't get a job, right? Like, I think that's one of the reasons why and this is my personal opinion. I don't want, like, this is me, not Samaritan. This is, I want to be clear, right? These are all my own personal opinions. For example, Corvallis Clinic Neurology Department. There's a difference now, obviously, with Optum buying them out. They, in the past, like 10 plus years, there were 8 neurologists. When I came, there were 4. Now there's 1. Okay. I'm going to tell you, neurology is one, as a neurosurgeon, and maybe that's because, and that's where I'm going to come from. I'm appalled at the lack of neurologists in this state for my patients' sake, right? Like it is appalling to me that the dearth of neurologists. But that is something that is happening across the board, across the country. So if we've gone from 8 to 1 just within our local community, right? And you are going to bring down specialist reimbursement or pay, you're not going to be able to recruit them here. I'm going to tell you that because other states are going to pay more, right? And so if you do not keep up with the reimbursement across other states, people are going to leave because physicians, PAs, NPs are just like anyone else. They need to put food on the table. Okay. And I recognize I'm in a very privileged position. Absolutely. But when we know how much a neurosurgeon is getting paid in Boston, in Maryland, and all of this is accessible data, right? You have to wonder what then really brings them here. And you want good quality physicians, right? Like you don't want to be, mucking from the bottom of the barrel, right? So that's kind of the difficult part. And that's why I say healthcare is rationed. You have to decide on your priorities. And I absolutely understand that our primary care specialists are, I mean, that I feel really bad for them. I mean, because of the economics and the reimbursement for primary care, they have to see 10, like 1 patient in 10 minutes. Their board, their panels are in the thousands. You don't get reimbursed for the number of my chart messages, the phone calls that you get, the refill orders. I mean, I'm very, very worried about primary care. But I have the privilege of saying that because I'm a specialist, right? I don't know what the answer is. I don't know how to help them other than just say primary care is so essential because if you don't have good primary care, and this is the thing that I really don't understand about OHP, because there are no copays for urgent care and ED visits, all of the care that primary care is doing for OHP patients are being done in the ED and urgent care spaces, which are more expensive, right? I just saw a note come across stating the patient went to the ED because they weren't sure when they were going to get their outpatient MRI and they have OHP and you know, and then they go to the ED for their MRI. These are all the downstream effects that happen when you don't have good primary care. I mean, and that's just one example, right? Like, and that costs money, right? All those downstream effects, like you're not capturing how much cost, although some people are, how much that's costing the system, right? So it's not so much you need to pay your specialists less. You just need to have more primary care. And then all those other things, the ED visits, the urgent care visits, all those unnecessary tests, hopefully the cost will come down. I think that's a better way to frame it than saying we need to pay our specialists less and our primary care more. Because I think they're the downstream effects that's where you're actually going to get your benefit, your bang for your buck. That's my opinion, though.
Great, thank you.
We have time for one more. Can we get everybody on the screen again so I can see? Is there anybody that has a question?
I think Mike has a question.
Mike, go ahead.
Yes, I appreciate your comments on attracting primary care or any physicians, and I'm pretty sure that the planning of the task force and now the governance board would fully realize that they cannot change physician reimbursement rates now, and hope to have the doctors come that we need. So that has to be part of the initial plan, is that there would not be a significant change in provider reimbursement, except for perhaps more incentives, financial and otherwise, for primary care.
I'm gonna. Oh, did you want to respond to that, Dr. Kim?
No, I was gonna say, yeah, I think I agree. I think the idea has to be that if you want to work with specialists to improve efficiency and reduce cost by doing potentially less procedures, it cannot be at the expense, because right now we're at a fee-for-service model, right? That's the problem, right? And so I think, what Medicare was doing was, well, if we pay specialists less for a procedure, they're going to do less procedures. I'm sorry, that's stupid, right? They're just going to do more procedures. Right? I mean, I'm sorry, like that doesn't make any logical sense, right? When you continue a fee-for-service model, right? Like an orthopedic surgeon doesn't want to make less money, right? They want to at least keep the same amount of income. So what you should be doing is working with your specialists to identify the patients that actually need surgery, right? And that will help reduce your cost, right? If you want to get away from the fee-for-service model, you have to work with your specialists, is what I'm trying to say, but still pay them and reimburse them what is nationally, what is across the board, right? Like that's what I think is the problem with the reimbursement model right now, is because it's fee-for-service, it's based on RVUs, right? And so if you can create a model where it's not based on RVUs and be what the acceptable rate of reimbursement is, or compensation, let's call it compensation, right? Across the board, and maintain that, but understanding it is not based on RVUs, that's attractive. Okay, I'm going to say that is an attractive model, right? Because then as physicians, then we're more incentivized to do the right thing, right? And we can really then think about quality metrics at that point, right? And not driven by the number of procedures that we're doing to drive our income. That would be my kind of take on how do we, one, recruit, right? And two, make sure that the right patient is getting the right procedure at the right time, right? From a specialist perspective. But I think Bruce had a question as well. I don't know if you want to take the question or not.
Sure, we'll take one from Bruce.
Well, thank you for Dr. Kim for being here. I was a patient of Dr. Yu at OHSU 10 years ago. With regards to our current system, as opposed to mimicking something that other nations have in Europe, throughout Europe, some form of social medicine that Taiwan has, South Korea has, North Korea doesn't have. Well, I guess they take care of the population by sending to Ukraine. I don't know.
Yeah.
Any rate, from my perspective, our current system, I would still be practicing medicine if not for our current system, because of the moral injury that it caused me over decades of just increasing control over how I treat my patients. And there's so many primary care physicians that have left practice because of that moral injury. It's a significant factor. And I just want to, bring that into the discussion as we consider how we recruit to Oregon under a state-based universal healthcare system.
I think looking and I'm not an expert in these, other systems by any means. I think there are distinct pros and cons of each of them, and they all do some things great, but I think we all have to recognize none of those systems probably do everything great, right? For example, South Korea, okay, because I do know a little bit of that system, okay? Even though they have a national healthcare system, it does not mean that everyone has the same amount of care. Okay. And it doesn't mean that people feel like they all have the same access either. And I think the finances of healthcare, unfortunately, there is rationing that has to occur in whatever system that you decide. And that moral injury will depend on, as a population, right, what we decide is acceptable or not acceptable, right? So in the current climate, I think the reason why what drives a lot of providers out of medicine is it's multifactorial. It's not just how people are paid, and that is part of it. I think the capitalistic version of healthcare we know doesn't work, and that does cause direct moral injury because we feel like we have to choose individually. But um, I think I don't know. I have thoughts about national healthcare systems because even like say for neurosurgeons, and I know this about Canada and the UK, like for a GBM, for example, a glioblastoma multiforme, which is a highly aggressive brain cancer, right? And in the standard of care here in the United States would be to do a very expensive surgery and do neoadjuvant chemotherapy and radiation, okay? With the potential progression-free survival or mortality benefit of 16 to 18 months, okay? In the UK, all they do is a needle biopsy and then a hospice, right? Because it's very expensive to do the interventions that I just outlined, right? But as a population, that is what they've determined, right, to be okay, right? Um, I think we take a much more nuanced version here where I would say I would decide a needle biopsy based on the location of the tumor, the potential risk of surgical resection, and then balance the risk and benefits and make that decision specifically with the patient to determine what their goals of care are, what their, quality of life expectations are. So there's pluses and minuses in any system, is what I'm saying. And that moral injury right now is due to the financial constraints, the insurance companies, them practicing medicine um, by creating barriers, and then the for-profit insurance companies. But in any system, even like Kaiser, because I mentioned them, they have guidelines. They have guidelines of when to refer or not to a specialist. Specialists are very expensive. The things that we do are very expensive. So in nationalized or all-encompass like single payer systems, specialists, you tend to not want to have them because they cost a lot of money. And that's a value proposition that you can have as a population, right? Maybe you want to expand primary care and give great, treatment for blood pressure management, diabetes, all of preventative services, and that's okay. That's a value judgment based on population, right? I wouldn't call that moral injury that you don't pay for a GBM resection. That's just what the population decided. But I don't know. I think it's really nuanced. I think I don't know that I answered your question, but there are pros and cons, I think, in a system.
Well, thank you for your response. I would point out that fortunately, on our Universal Health Plan Governance Board, we have a local specialist from Taiwan, Dr. Chunwei Chi, who is helping us as we navigate what is the best system for Oregon. So we're very grateful for that opportunity.
Absolutely. It sounds, definitely having subject matter expertise is really important. And then, like I said, it depends on the values of the population, right? Like what is the goal, right? And I know that from an OHP standpoint currently, they want at least their goal set or the rationale is that they want to cover as many people as possible, but that means that they have to ration care and they don't cover other things, right? And that is valid for any system as long as I think it's done with a thoughtfulness and intention of what the values of that population are and reflect it.
So, as
Okay.
the father of a disabled child that is in the Oregon Health Plan system, I'm actually uh, very pleased with the level of care that our son has been getting through the Oregon Health Plan.
I'm glad. And I think that is actually pretty true for many Medicaid systems for children with disabilities because my stepson has a heart condition and he's in Southern California. Right now, he's in Cincinnati having heart surgery. So I absolutely recognize that there is great care that can be provided through these systems. But I'm saying it there's going to be rationing at some level. And I think we all have to decide what level is appropriate, right? And I don't have that answer for you.
Well,
Thank you.
thank you for being here. I really appreciate your perspective.
My pleasure.
Yeah.
Mark?
Yes. I do. I also want to express thanks for your perspective and taking the time with us.